Good morning, distinguished speakers, honored guests, and all participants joining us today, both in person and online. Assalamualaikum warahmatullahi wabarakatuh. On behalf of the Department of Health Policy and Management and Center for Health Policy and Management, Universitas Gadjah Mada, it is my great pleasure to welcome you to this expert lecture titled Global Health Finance After COVID-19 and the Future of Universal Health Coverage. My name is Raras, and I will be your master of ceremony for this lecture. This morning's discussion brings together academic insight and global health perspective to reflect on how the pandemic has reshaped health financing strategies worldwide and what that means for the future of universal health coverage, a vision that continues to challenge health systems everywhere. We are deeply honored by the presence of our distinguished speaker, Professor Peter Berman, MSc PhD, who is a health economist with 40 years of experience in research, policy analysis and development, and training and education in global health. Prof. Berman is a professor of the School of Population and Public Health, University of British Columbia in Vancouver, Canada, and adjunct professor in global health at Harvard T.H. Chan School of Public Health, Harvard University. Prof. Berman has worked extensively on health system reform and healthcare development issues in a number of countries, including Egypt, India, Colombia, Poland, and Indonesia, contributing to many impactful initiatives throughout his career. We are also privileged to be joined by our moderator, Professor Dr. Laksono Trisnantoro, MSc PhD, Professor at Faculty of Medicine, Public Health and Nursing, Universitas Gadjah Mada, whose expertise in health policy has shaped national and regional health system dialogues in Indonesia and beyond. We hope that today's discussion will contribute meaningfully to the ongoing discourse on global health financing and universal health coverage, offering valuable insight for the academics, practitioners, and policymakers. To commence the session, it is my honor to invite our moderator, Professor Dr. Laksono Trisnantoro, MSc PhD. Please welcome Prof. Laksono to guide us through the session.
Well, selamat pagi. Good morning, everybody. Now, I would like to have some presentation to introductions to my senior, my colleagues, Professor Peter Berman, and actually he speaks bahasa. Dia bisa bahasa Indonesia because he finished his PhD, I think, how many years ago? 45 or 40 years ago. Yeah, and then the field study was in Sapuran, Kepil, Wonosobo, Central Java, and he lived in Indonesia for 1-2 years, and then after his PhD in I forget, Columbia, Cornell University. And then he spent many times. It's like a frequent visitors to Indonesia, and he has a lot of work with Pak Ascobat Ghani, Prof. Ascobat Ghani from FK-KMK, a very close friend, and also with the late Professor Lukman Sutrisno from UGM. So Pak Peter Berman, welcome home Pak, selamat datang di sini ya. Kita akan diskusi banyak mengenai apa yang terjadi di global. Tapi sebelumnya saya akan sedikit mengantar mengenai pendanaan kesehatan di Indonesia ini sebagai satu semacam konteks ya. Kenapa kita bicara mengenai global financing and after UHC, after COVID and the future of UHC. Oke, mari kita lihat ya. So we speak mix bahasa Indonesia and English. Okay, so this introduction actually is concerned with about health finance, and we have just MOH just released the national health account data from 2014 to 2023, so about 10 years of health finance in Indonesia, and we can see that in this health account there is an increase of social health insurance scheme, yeah, but also the increase of out of pocket, and the private health insurance is stagnant during the 10 years of BPJS. So we can see this is the feature, and the non-public scheme is actually is decreasing. The public scheme is increasing up to 57.4%. And then it's very interesting to look at the future, uh, how high we can go. Like in Japan, maybe about 90% is a public scheme, but in Indonesia, maybe I think it will be difficult. It's more than 60% because we can understand how the government fiscal condition at the moment is not so bright in the context of the international economy, the tariff agreement, the uncertainties about the future of world trading and many things. Okay, and then from this, we can see that the out-of-pocket is increasing. Out-of-pocket spending by healthcare providers and by function, and mostly at the hospitals and using curative care. So this is the point that it's slightly increasing. And then also, this is very important issue for UHC. At the moment, we experience what we call like the rebound after COVID-19 situation. So there's a big increase of social health insurance utilization. So you can see in this graph that BPJS claim and visits is increasing very, very sharp. Ya. Jadi ini naik sekali ya, total expenditure per JKN per kapita juga meningkat ya. Nah, this is the big question about the UHC after COVID, because actually when we look at back to the experience during the COVID times between 2020 to 2022, in this graph, we can see that actually in historical perspective, the JKN can be classified into maybe 3 periods that will be discussed maybe in the next month with the historian. This is the JKN before COVID-19, yes. And then JKN with COVID. Why I said with COVID? Because actually there is a big financial resources from PEN, dana pemulihan ekonomi nasional, to BPJS, because all of the BPJS members that treated as COVID patient at the hospital, it is funded not by BPJS budget but by PEN. So that's why BPJS has surpluses. Yeah. But after 2022, post-COVID, then there is an increase of the claim, and then you can see that the claim ratio is 105.0%. Yeah. Okay. So this is the situation is like similar with pre-COVID situation, but thanks to the COVID that BPJS still can pay the claim. However, in 2024, this graph is increasing, so the claim ratio is much higher, and then in 2025, there's still a projection that our claim ratio is much more than 105%. And this is becoming like a big concern of how the future of UHC after COVID-19. Whether we can be like survival of the COVID using like long-term sustainability, or we have to write down again the regulation or the financial arrangement for BPJS. Okay, so this is the post-pandemic return to deficit. This is the point, and actually, if we look at in the pre-COVID experience, we have what we call like reliance on government subsidy, and this is becoming very important. That if the government should pay or they have to pay, we have to pay, then how the fiscal capacity of the government for doing this kind of, let's say, like a bailout or funding the shortage. Jadi ini ada satu pertanyaan yang menarik ya mengenai ke depannya, karena saat ini memang terjadi suatu defisit besar dari GDP ya, APBN terhadap GDP ya, sudah semakin meningkat. Ya. Jadi ada kemungkinan pemerintah di masa mendatang akan kesulitan untuk mengcover defisit di BPJS ya. Sehingga ada suatu urgensi atau kepentingan untuk mencari uh, financing solution yang lebih sustain lagi. Oke. Nah, sekarang how the future of UHC, that is the point that so when we look at back to the pre-COVID-19 situation, we can see that most of the deficit is like happening, yeah, in the PPPU. So the red bars is the deficit, yeah. It is the PPPU, the non-formal members, yeah. Okay. And then after the COVID, and if you can see, we can see that the surpluses because the PPAPPN, the black one, the bar, is in 2019 there was a high increase of PPE APBN premium, and it makes like how many millions? 30 trillion maybe. This is the leftover, yeah. And then because the COVID, patients are paid by pen, so BPJS has surpluses. Yeah. Okay. And then number two is the problem of geographical inequity. This is also happening. Why we have big problems in like expanding our medical facilities? Because actually, for example, for this, for stand for cardiovascular disease, we can see that in 1990, sorry, in 2014, it's like this. Yeah. Okay. And then the point is that when we have the mandatory spending, we have the 10% of the local government budget should be devoted to health. That means it's very easy for PPI APBN. Ya, jadi ada uang masuk ke, sorry, PPI APBD, local government PPI. And then what's happening? The local government, they don't have enough budget for attracting medical specialists, for constructing hospital. So the point that during the 10 years of BPJS, the supply side is not well developed. And that means the budget from the local government comes to the central and then used by mostly by the big cities claim users. Jadi ini ada satu masalah yang cukup menarik ya. Jadi tidak adanya suatu dana kompensasi ya. Artinya apa? Daerah-daerah yang kekurangan dokter spesialis dan sebagainya itu tidak bisa klaim yang sebesar yang ada di Jawa. Nah, sehingga dana PBI APBD yang masuk melalui kebijakan mandatory spending 10% tadi itu banyak dipakai untuk klaim-klaim yang justru bukan kembali ke daerah terpencil tapi ada di kota-kota besar. Nah, inilah yang jadi satu isu yang seperti shallowing, menyedot dana ke provinsi-provinsi besar. Sehingga the ultimate result is the equity is not yet achieved. Yeah. This is the graph that can be shown this, like the small kid should be like that, having two boxes, but the reality like this, yeah, the equality, yeah. Maybe not only equality, but it's worsening than equality. Yeah. Okay, so that means we had the experience of not in social justice, and then the financial sustainability is not so good. Okay, so how the future, and this is the thing that maybe Pak Peter can make some global perspective about what's happening in other countries. Yeah, yeah. So we can see that the government faces difficulties in fiscal, and the point that the economy is increasing, but the tax ratio is not good in terms of number. We can see that the ratio pajak, tax ratio, the tax that can be collected compared to GDP is declining. The GDP increasing very, very steep, but the tax ratio is declining, only about 9 to 10%. Yeah. In Scandinavian country, it's about 25 to 40% of the GDP. In Thailand, 17. So actually, we are very, very poor. Our country, the government has limited fiscal capacity for funding welfare activities. And at the moment, we have not only had, but free lunch, Pak. Makanan gizi apa? Makan siang bersama ya, makan siang gratis itu ya, itu it takes a lot of Indonesian budget. It's not easy. Okay, so this is my question for my last slide. I hope that Pak Peter can explain to us about how the global situations of health finance and how the future of UHC in many countries, and whether we have to make like a big change in our strategy for keeping the UHC still on the track for a better equity, and the financial sustainability is good. Okay, so please, Pak Peter. Yes.
Hit this one? Yes. Okay. Thank you. Terima kasih, Prof. Laksono. And very nice to be with you all today. I will not try to give my talk in Bahasa Indonesia. Mungkin terlalu sulit. But if there are some questions and discussion, I can certainly understand and give you some response. So I think I need to share my screen, right? Ole? Okay. Share. Okay. And let's go there and okay. 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 Saya kira bisa dilihat sekarang ya. I will, Prof. Laksono has given us a number of very detailed and important observations and findings about the situation in Indonesia. And I would like us to come back to that at the end of my talk, but I'll try to give a little bit of a larger perspective on the global situation, not only about finance, but also about UHC, because I think there's needs to be some more clear thinking about what is UHC, what does it mean for different countries at different levels of economic development and so on, and how can this be used in a practical way so that countries follow health policies and health systems development that is feasible as they grow. So now let me see if I can change my slides. Okay. So I'll talk a little bit about the context and environment, some of the positive and negative factors that have come into play since COVID-19. I'd like to talk about more specifically about what is UHC, what is meant by UHC, and clarify some of what I think have been some of the global uncertainties and confusions about this concept. And what does that tell us, or what does that mean for health systems and programs, for the role of primary health care, hospital-based services, the challenge that many countries face in meeting the high-cost needs of people needing high-cost treatments and therapies, and how does that really influence health system development. And then we'll come to Indonesia, and hopefully we'll have some interesting discussion. Okay. So fortunately, the pandemic is largely behind us. Of course, there's still some evidence that the virus of COVID-19 is around and continues to evolve, but it's no longer a major life-threatening event in many countries. I will say that this was a very unusual event for many of us, in the sense that the COVID-19 virus not only had very significant negative health outcomes, but also it lasted for a very long time. And the virus evolved several different major evolutions, which meant that efforts to address it were were not the typical public health response to outbreaks couldn't be applied as easily in the context of COVID-19. Clearly, it was a major shock to the global and national economies. The US National Institute of Health estimated the global cost of COVID-19 at 16 trillion US dollars. That is a very significant percentage of global GDP. What was the source of this financial shock? There was significant public spending, not only to address the pandemic itself, but to mitigate its effects on employment, on businesses, and on people's well-being. Many countries incurred large amounts of public debt in order to meet these requirements. Now, some countries were more affected than others by the disease, and they also bore a greater burden of the response. In the United States, the inflation that we experienced in the last couple of years, which fortunately now seems to be subsiding, could be traced in significant part to the large expenditures of the government to meet people's needs of who are losing their jobs, who couldn't go to work because of the pandemic, and so on. So, and this is true in many countries, and I think was true here in Indonesia as well. Now, the good news, and this slide has some positives, is that basically, I think today economic growth and trade have resumed and rebounded for much of the world. As Prof. Laksono showed us, Indonesia has been doing reasonably well in this context in the last couple of years. Hopefully that will continue. I won't say anything about some of the headwinds that may be coming up now to affect global trade, but hopefully we will see this continue. Now, some of the negatives for global health financing, I think we really need to pay attention to. Firstly, there have these significant increases in public debt, particularly affected the low-income countries. The government debt to GDP ratio in the lower income countries currently ranges from about 30 to 65%. That means the level of debt is 30 to 65% of the total size of the economy in a year. That's a very high debt burden. And of course, the servicing of that debt, the paying of interest, is taking up a large share of public budgets. In many countries, it is estimated that debt servicing costs more to the government than the total spending on health and education. So this is really a significant burden. Now, we do see efforts globally by the international organizations to provide some relief. The IMF and the World Bank have been making significant new expenditures to support economies in the low-income countries. But these efforts to aid economies are sometimes accompanied with conditions. And for example, I am currently doing a lot of work in East Africa, in the country of Ethiopia, and they have received World Bank IMF support. But as part of the conditions of accepting this support, the currency was devalued by 100%. So what used to cost $1 cost $2. And also there has been some pressure on the government to reduce the number of public sector employees. And of course, the biggest employment is health and education, health workers and teachers. So I think that one could question, those of you who are old enough to remember the period of structural adjustment in the last century, maybe we are entering a period of what I call structural adjustment 2.0. That is, some significant fiscal pressures on governments to reattain some kind of economic balance. And that's having significant effects on health systems and programs to meet health needs. We've seen this dramatic reduction in external aid, especially in the United States. essentially the termination of a very large percentage of USAID support to countries. This is especially is affecting the lower income countries, but other international support has also been declining, including through some of the multilateral organizations like Gavi, Global Fund, and we don't know whether World Bank, International Development Association, which provides subsidized loans to low-income countries, are also emerging new calls on public spending, for example, most notably related to climate change. So while health remains an important issue, there are new challenges that are also putting pressure on lower income countries. And these are some of the main negatives. Now, I wanted to just share with you this table from a recent report from the Africa CDC that shows some of the estimates on ODA cuts. And you can see the bottom of the United States on this table, a cut by 83%. But all of these other rows show other countries that have been cutting their official development assistance budgets. And so this is not just the United States, and countries that have relied significantly on these sources of support to support their health systems are facing a very urgent challenge, how to make up for the difference. And just to kind of also point out my story about devaluation, if you are importing sizable amounts of health commodities, drugs and supplies, and the price doubles overnight, this is really a significant pressure on your government budget. I think my connection just got interrupted, so let's wait till I reconnect. It says connecting. Okay, let's share again. Oh, this one, let's see. Okay, I think I'm back. Okay. All right, let me turn now to this question about universal health coverage. And I'm going to say some things many of you are very familiar with, but I think it's worth unpacking this a bit. So this conversation started in 2005 at the World Health Assembly. Universal health coverage was defined as guaranteeing access to all necessary services to everyone while providing protection against financial risk. Now, I've added that language in the brackets there, so it's guaranteeing access to necessary services while providing protection against financial risk. But the point I want to emphasize is this was a very ambitious aspiration for health systems. All health care that people need would be provided to them without financial risk. Okay. Whoops, there I got disconnected again. Come back again. Okay. I do have my PowerPoint on this stick if you want it. Countries attained this goal of universal health coverage, this would really be a wonderful achievement. It would produce the highest health outcomes a system could achieve and a very high level of health system performance in terms of financial risk protection, quality, access, and equity. So this is a very admirable aspirational goal. Margaret Chan, then the WHO Director General, called this, she said, "I regard UHC as the single most powerful concept that public health has to offer." Now, moving forward, in 2016, when the Sustainable Development Goals were adopted by the international community, following the Millennium Development Goals, which covered the period 1990 to 2015, the Millennium Development Goals had very specific health outcome targets related to maternal health, child health, disease control, and so on. But in the SDGs, SDG number 3, which focuses on health and well-being, has 13 targets, including one of them being universal health coverage. And many refer to SDG 3, they refer to SDG 3.8, the one on universal health coverage. And this has led to a great deal of global attention to this goal, including at the United Nations General Assembly, has had multiple high-level meetings on UHC progress, and the World Bank and the World Health Organization released something called the Global Monitoring Report on UHC, which is definitely something you should take a look at, and I will show you an example from that in a moment. So, what's interesting is that when SDG 3.8, which emphasizes UHC, was adopted, some change was made to the language of the 2005 World Health Assembly resolution on UHC. The most important one is that this doesn't refer to all necessary services, but it uses language referring to essential or priority or basic services. For SDG 3 is ensure healthy lives and attain well-being for all at all ages. But SDG 3.8 says achieve universal health coverage, including financial protection, access to quality essential healthcare services, and access to safe, effective, quality, and affordable essential medicines and vaccines for all. It's important to note that this term essential was not defined in the SDGs, and it has not been defined in any very specific way by the international community. Also, another little footnote here is that you might notice that the financial risk protection objective isn't qualified in relation to essential services, but seems to cover all healthcare. So in a sense, SDG 3.8 calls for achieving access to quality essential health services, but financial protection for all health needs. Okay, and these are not trivial differences with the original declaration. Okay, so another comment that I think is worth understanding is that the term coverage is a very interesting term to have used, universal health coverage. The term coverage has two definitions. In the public health definition, coverage means the percentage of those who are in need of a service who receive that service. So it looks at the denominator as those who need a service, and it calculates the percentage who receive it. The term effective coverage has also been used to add quality to that thinking. So the percentage of those who need a service, who receive it at an adequate level of quality to produce the desired outcome. Okay. But in the insurance world, coverage means something different. It denotes an entitlement. So you can have insurance coverage, meaning you are eligible to receive benefits, but it doesn't necessarily include the fact that you actually receive those benefits. So people can have an insurance policy, but they may or may not make claims under that policy and receive payment as a result of those claims. And I think this has also been a source of some confusion, so that some have talked about we should use a term universal health care, not universal health coverage. Okay. And if you look at the famous WHO cube from the World Health Report in 2010, the box in the cube relates to financing, but it doesn't relate to the realization of the coverage. So you can see on the different axes of the cube, the term covered is used. Which services are covered? Does that mean which services you have an entitlement to receive? Or does it mean which services did you actually receive? If we're looking at the financing, it's not always entirely clear. So I think I know this is very pedantic, if you will, to use the English word, to explore the language, but it actually has real implications for what's been happening in the world. Okay. All right. So now the how has it been going with UHC? So my slide changed here, but it's coming here still. UHC progress for the lower and middle income countries has mainly focused on these this narrower benefit package of essential or priority services. I'm disconnected again. Yeah.
Okay. Oh, yeah.
You're doing it?
Yeah. We'll kids to that.
Okay.
It's slow.
Yeah. So I should disconnect from Zoom? Yeah. You can use this?
Yeah.
Okay. Can we go full screen? There we go. Okay. So how is it going? It's mainly focused on this narrower package. There's been significant progress since 2000, but improvements have stalled in recent years. And we see large differences across country income groups. The progress in financial risk protection has also been mixed and is hard to interpret because in some ways, as incomes go up and people's demand for healthcare goes up, they consume more and they're willing to pay more out of pocket for that if they have to. So in some ways, we may be also facing a challenge. WHO's assistant DG some years ago was quoted as saying, despite the progress, UHC coverage is stalled or not on track, and only about half the world population will be covered by 2030. I think this has even become more urgent in recent years. So here, I just wanted to share a couple of charts from the recent World Global Monitoring Report. On the left-hand side, you can see the trends in the UHC Service Coverage Index from 2000 to 2021. And you can see the leveling off of progress, especially since the period of the pandemic. And this seems to be continuing today. The Service Coverage Index, which was developed by the World Bank and WHO, basically represents about a half a dozen different indicators of service utilization: maternal health, child health, some disease control, and 3 indicators related to non-communicable diseases or adult health. So it's a good representation of something that many would consider should be included in essential services, but it is not a representation of a very broad package of healthcare services. And the chart on the right-hand side shows the trends in the incidence of catastrophic health expenditure using different levels of the indicator as percentage of household overall consumption expenditure. And you can see that both indicators using a 25% or a 10% threshold are still increasing over this period of time. So essentially, the very aspirational goals of UHC are difficult to achieve in the current environment, and even some of the narrower goals of UHC have been difficult to achieve in a global picture. Now, some countries are doing better and some countries not so well, and I won't go into all those details, but the Global Monitoring Report, which you can download, has a great deal of detail about this and is worth taking a look at. Okay, so what's the meaning of all of this? All countries are facing very significant financing challenges in achieving the most ambitious concepts of UHC. This is not limited to the lower and middle income countries. Even the high income countries today are facing these challenges, okay? As Prof. Laksono said, I spent a number of years in Canada at the University of British Columbia. It was kind of surprising to me that in much of Canada, 20% of the population does not have access to a primary care provider, despite the fact that the government pays for primary care. So it isn't just a matter of financing, it's also a matter of the supply of healthcare. And we are seeing in many of the Western European countries and in the United States and Canada, the challenges of financing access to some of the higher cost interventions, hospital-based interventions, or new higher cost drugs and interventions for non-communicable diseases. So I think it's important to note that UHC is a wonderful aspirational goal for health systems, but the challenges are not limited to just the lower and lower middle income countries. The scope of what is needed is quite broad. In the lower income countries, the current spending levels limit the ability to achieve even this more limited concept of UHC. So if we think only of the indicators in the Service Coverage Index, which are largely related to primary healthcare service delivery, the many low-income countries are spending only in the area of 10 to 15 US dollars per capita per year to deliver primary healthcare. And that probably is not sufficient to achieve universal coverage, even with the more limited package. So, but in some of the lower middle income countries and the middle income countries, some version of SDG 3.8 is achievable with good health system design and management. But that means we need to be very clear, what is the content of that UHC? What is included in that package of essential services, and how can we assure that at least that package of services is delivered to everyone with financial risk protection? We can do more than that, but we should at least make sure we are doing that, okay? And one of the challenges that many countries are facing is ambitious new programs, and I think as Prof. Laksono started us off, Indonesia's very ambitious health insurance program is creating some pressures which may be not entirely aligned with achieving this universal health coverage, even in a more limited way. So comprehensive health insurance programs in a number of countries and are potentially competing for the resources that might be needed to achieve this narrower definition of UHC. So let's turn now to Indonesia, a little more detail. Current per capita spending in Indonesia is approximately 145 US dollars. This was a figure from 2023. In my experience and in international comparisons, this should be sufficient to achieve one of these partial versions of UHC. And that's great, you know, because in other countries where I have been working, and again, referring to Ethiopia, you know, the total spending in Ethiopia is $40 per capita per year on all healthcare, hospital, PHC, and so on. That's a real challenge to achieve some version of UHC 3.8. We think a great deal is possible at that level of spending, but in Indonesia, you are already wealthy enough to afford to achieve that very significant version of UHC from SDG 3.8. But you are also experiencing challenges with new needs and demands related to non-communicable diseases, growing levels of diabetes, cardiovascular needs, cancers, and so on. And also what you're experiencing as well with your ambitious national health insurance program is that unmet needs from the past start to accumulate and increase need and demand in the current period once entitlements are given. So the question really facing Indonesia, but also many other countries, how to balance that need and demand for medical care, especially higher level medical care, with the need to mitigate and reduce the future need and demand through population health initiatives. And how to achieve in this balance a financially and operationally sustainable system. And I think you're, I guess, unfortunately, Indonesia right now is a very important example of these challenges. And also, a particular issue in Indonesia is how to manage the large regional diversity in geography, healthcare supply, and economic conditions. Some countries that have been more successful in finding this balance face fewer of the challenges of this geographical diversity that Indonesia has, being a country of thousands of islands strung out over thousands of miles in an archipelago, as opposed to a state which is smaller in total population, has a unitary geography, and maybe better ability to access transportation and achieve access to higher level healthcare, physical access to higher level healthcare. One last slide I have. So JKN right now is the world's largest single payer health insurance scheme. No other country, I think, even comes close to having such a large single payer health insurance scheme. In the United States, we have a single-payer health insurance scheme for our older population, Medicare, for those over 65, and that is large, but it is only partial. It only covers those over 65. You have very high enrollment, but as we've seen a few minutes ago, there are significant financial challenges and also gaps in inequalities in benefit distribution. Interestingly, the activities that are more related to SDG 3.8, the basic or essential package, are largely delivered in Indonesia through primary healthcare, which is still mostly financed by government budget transfers and not by JKN. Recent studies that we've done in kabupatens in Indonesia suggest that JKN funding for primary healthcare may only be covering 10 to 20% of the total expenditure on primary healthcare. So you have an interesting situation where a large coverage scheme, which is oriented to UHC, but the government budget still separate from that scheme, covering most of the primary care for the more basic services. And this has really raised the challenge of how to finance the need for acute medical care with the population-focused prevention and promotion interventions. Your Minister of Health has recognized this issue very clearly, promoting a new integrated PHC program, ILP, as an urgent need to prevent and future high-cost illnesses to make future health financing more sustainable. But can it be done in this complex environment? I think is an important question. Also, you have very significant and growing non-government healthcare delivery, private sector healthcare, funding, organization, and also the questions of governance, decision-making, regulation between these public and private initiatives, and a number of other big challenges you have. So I think you know your situation better than I do. Let me stop there. And terima kasih. And hopefully I've helped illuminate some of the global perspective.
Oke, terima kasih. Tepuk tangan dulu. Yes, thank you very much, Pak Peter. Ya, ya, menarik sekali apa yang disampaikan oleh Pak Peter. Ini ada beberapa poin yang mungkin bisa kita bahas dalam diskusi yang masih, waktunya masih panjang nih. Ya, yang pertama memang kondisi global itu post-COVID cukup berat ya. Jadi terutama untuk negara-negara yang miskin ya atau sedang berkembang itu utangnya meningkat tinggi, Pak ya. Dan Indonesia pun dana untuk pemulihan ekonomi nasional itu sebagian besar dari dana hutang ya. Jadi tolong dilihat bahwa COVID itu memang mempunyai efek menambah beban hutang kita, dan tentunya fiskal kapasiti kita untuk welfare state akan menyempit untuk bayar karena pembayar hutang tadi. Kemudian yang kedua yang menarik juga kita tadi bahas bahwa Pak Peter remind lagi bahwa UHC itu bukan hanya dalam tanda kutip itu pembagian kartu ya, anggota tadi ya. Seolah-olah dengan misalnya Indonesia 99% untuk sudah menjadi mendapat kartu atau menjadi anggota BPJS itu sudah UHC, karena ada satu indeks yang sangat terkait dengan akses itu, yaitu indeks cakupan pelayanan, service index ini yang WHO dan Bank Dunia juga monitoring, dan kalau kita lihat dari dokumen yang terbaru, memang Indonesia untuk indeks ini sangat-sangat ketinggalan. Jadi, Jadi ini yang menarik ya. Jadi kita perlu betul untuk kembali ke apakah UHC itu sebuah cakupan untuk pelayanannya atau cakupan kartunya. Nah, ini jadi satu isu kunci yang perlu kita bahas ya. Kemudian juga mengenai paket standar, ini yang perlu kita lihat. Ini jadi satu hal yang sangat menarik karena kita sendiri paham ya, BPJS kita paketnya itu lebar sekali sampai transplant pun bisa didanai. Ini jadi satu isu kunci ya. Nah, kemudian dalam konteks perbandingan dengan luar negeri, sebenarnya Indonesia itu lebih dibanding seperti Ethiopia tadi mempunyai ya situasi lebih baik ya dalam konteks anggaran ya. Tapi cuman tadi kembali pada tadi yang kita akan bahas, Indonesia itu betul-betul luar biasa besarnya ya, dan arkipelago kepulauan kita punya 520 kabupaten kota di 7.000 pulau yang didiami dengan 38 provinsi. Kita bukan seperti Thailand. We are not like a Thailand that although it is a long country from south to the north, but within 2 hours in Thailand the access is there. But Indonesia mungkin hanya 10 kilometer bedanya, tapi terpisah oleh selat itu sudah susah nih, karena kita arkipelago kepulauan. Nah, hal-hal seperti ini yang kita perlu betul untuk melihat ke depan ya. The future of Indonesian UHC itu bagaimana? Setelah kita mengalami pandemi COVID yang begitu berat sekali ya untuk bangsa kita ya. Nah, kita bagaimana? Nah, ini mari kita diskusikan, dan silakan teman-teman yang di sini yang mau langsung bicara melalui yang di ruangan ini ataupun melalui Zoom atau masukkan ke chat, silakan. Ada? Kami tunggu. Sudah ada belum Pak yang mau tanya nih? Atau komentar? Oh, ada. Oke, Pak Lutfan. Pak Lutfan. So Pak Lutfan is the chief, the head of Department of Health Policy and Management at the Faculty of Medicine, Public Health and Nursing. Silakan Pak Lutfan.
Selamat pagi, very good morning, Pak Peter. At the first slide you mentioned that the country experienced debt burden I think including Indonesia also, since that according to the Ministry of Health, they actually secures the during the pandemic, one of the priorities to get the vaccines, and of course that this is costly, and they got the loan basically to secure 1 million vaccine, if I'm not mistaken, at the beginnings. But as Pak Laksono mentioned also, that the burden is also then widening, because for the social economic purpose also to be actually facilitated during the pandemic. Just wondering whether this affected also others, since that probably this is the strategy, the only strategy at the moment to basically ensure that we have the mitigations actions that I think will be also very useful to do that. But hopefully you get the message.
No, I think that this Indonesia definitely was affected by these pressures of the pandemic, and of course the need to be able to procure essential medicines and so on. Fortunately for Indonesia, your economic situation has been somewhat more positive than some of the other countries, which includes not only having resources, but being what you might call a good credit risk. So there's the opportunity to borrow money to finance some of these urgent needs. And of course, the World Bank has made significant loans to the government in support of your health program. In lower income countries, this has been the problem of the debt burden, is that they are not having the revenue, and they are not seen as such a good credit risk, right? And that's why we have been entering this period of readjustment in many of the lower income African countries. So, yeah, thank you. I will say also that the international supply of some essential commodities, vaccines, drugs for tuberculosis, HIV, and so on, these are being challenged by these reductions in external support. I mean, Gavi the Global Alliance for Vaccines and Immunization just had a fundraising round, and they were raised about 20% less money than they wanted to raise. So this will mean there will be some pressures on some countries to what they call graduate from this.
Yeah. So that's mean the global condition will be, yeah, I don't want to say like worsening, but at least not as good as before COVID.
Yes. Yes, I would say that's right. I think we saw a dramatic increase in global support for basic health care from the year 2000 until right before the pandemic. There were some signs that external funding was leveling off in 2000, in a couple of years before the pandemic, but now it is actually declining. So, yeah.
So I think this is an interesting issue because actually at the moment we are also conducting some historical analysis on what's happening with the global health policy and Indonesian health policy situation before and after COVID. Yeah.
Yeah.
And some historians also mentioned that this is for Indonesia, not yes, COVID is very, very big what's called like influence to the future of Indonesia.
Yeah.
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 This is the point. Okay. Other comments, please? Yes. Microphone.
Thank you for the opportunity, Prof. Laksono. My name is Zikri, Prophet Peter. I would like to ask about, it's maybe a little bit operational, but what is the ideal role of social health insurance corporation governance based on your experience? Should they act solely as a payer only, or should they also provide service guidelines? Because in Indonesia, from my view, especially in community health centers, there are two pathways for hypertension, which makes the implementers is confused. And in your presentation, you mentioned about the new integrated PHC program, or ILP. It's actually fragmented by the social health insurance itself, because there's two care pathway on that. I think that's all. Thank you.
Thank you. Well, you asked a very general question, which is, should social health insurance provide guidelines for care? And I think a purchaser should be able to provide some guidelines and conditions around the purchasing, right? I mean, this is one of the powers of having a purchaser, right? And I think in much of the global conversation, there was a sense that government service delivery funded by budgets, basically providing physical inputs, supplies, salaries to health workers, had very weak tools for providing incentives or guidelines for care. The tools were mostly advisory and relied on the positive motivation of the workers themselves, right? And we know people are not always so positively motivated in the world. So there has been globally a big push and a big interest in new forms of purchasing, strategic purchasing, incentives, and how those operate. And these are, and sometimes in government, there have been mechanisms put in place to use these tools, but payment organizations like social health insurance are particularly well suited to use these tools. Now, that's very general. Now, more specifically, sometimes the problem occurs when there are multiple payers, multiple sources of financing the same services. And the guidelines and the incentives embodied in the payment mechanisms may not be aligned well with each other. They may be contradictory, right? And this is when you describe the situation with hypertension in PHC, this may be what you're observing, is that on the one hand, the Kabupaten government, largely with funding from national budget sources, is financing screening and some basic treatment for hypertension. And JKN is also giving capitation and some other incentives and some disincentives to the health workers in the same facilities. How well aligned are these different channels? Some of the evidence are well aligned, right? And from the and then this creates part of the problem. And this is not simply a technical problem of finance and management. This is also a governance issue. Who has the authority to do these things, and who has the final decision-making role in doing this? And you can see in PHC in Indonesia, some of this authority is vested with the Kabupaten and with the Dinas at the Kabupaten level. Some of it comes from the rules and regulations from JKN, which are decided centrally, and some of it comes from the budget lines that emerge from other central government sources. And it's important to note that it's not just from the health ministry, but even the Ministry of Village and Community Development provides funding for the work of the Kader Kesehatan, right? And so on. And they have their own guidelines for these things. So this is, so it's not that there should not be guidance from the payer, but the guidance needs to be designed properly and well aligned.
Yeah. Very interesting. Actually, when we look at the law, the new law mentioned that the coordinations and synchronization should be under the MOH. Yeah. But at the level of the district head office and province office, there is a problem because our research in some districts, it is difficult to have like a planning session between BPJS and Dinas Kesehatan. It's not easy. Yeah. Okay. Now we have some raise and yeah.
Laksono.
Yeah. Okay, Ibu Dia and next after that Pak Bambang from BKPK. Okay, Bu Dia, please. Yeah.
Yeah, thank you for your interesting presentations, Pak Peter. Yeah, so you have mentioned that we are a little bit shifting from the terminology of UHC from universal health coverage to universal health care. So in your opinion, you already mentioned also 3 terms, including essentials, priority, and basic. So what lesson can we learn from maybe from other countries' experience on who will determine these 3 things of the priority, essential, and basic, and what should be taking into account to determine which benefit could be essential, could be priority, and could be basic. Thank you very much.
Thank you. That is a very difficult question, Ibu Dia. So clearly, we would greatly like and prefer to be able to meet as much of the need as possible, right? And the question of what is essential or priority or basic is a very difficult political question, and also has some difficult technical aspects as well. I personally prefer to use the word priority because basic sounds too low level, right? And essential, it kind of means implying that something is essential and some other thing is not essential. And of course, to the individual who is experiencing the not essential, it is also essential, right? So, you know, we say in health financing sometimes, you know, it's it's not essential until it's your uncle. So, or your auntie, to be balanced. I think this is a very difficult problem for many countries. And one of the ways forward is to set some priorities which must be achieved, and then to try to create some mechanisms for achieving things beyond those priorities, even if that's going to be incomplete, right? And one example of this that I think was widely documented occurred in Mexico, where they created a defined benefit package during the period of the Seguro Popular reforms, but they created a special fund that the government managed to meet higher cost needs that were not included in the defined benefit package. And that's not a perfect solution, but I think it is a practical solution. And then they had to make difficult decisions who could be eligible for that special fund, but they could use social income criteria and geographic criteria and so on for the allocation of that special fund. And the other big problem, I think, in these decisions is that once one has made a commitment for a much wider package of services, it is very difficult to reduce that commitment. It's going to be, but people do understand. I think people do understand that a commitment that is not fulfilled, that is not met, is not really a commitment. And I think the unmet commitments do undermine the confidence and trust of the population in programs. And we do need people to feel confident and trusting in the commitments we've made to them. So I don't have an easy answer to your question, and but it's an important one. And there has been I would add, there has been some significant work and research done on community engagement and public discourse processes of how to achieve consensus about these kinds of packages. My colleague, Professor Norman Daniels at Harvard, has written about this, and I do think that this is something worth studying in health systems. Indonesia has a long, very admirable tradition of musyawarah dan mufakat. So maybe you are well suited for handling these problems. Thank you.
Yeah, interesting question or comments. So actually, what you are saying is we have to broad in terms of medical benefit, betul nggak? Artinya kita itu besar sekali medical benefitnya. Jadi janjinya BPJS itu besar ya, sampai ke transplantasi ginjal, obat-obatan cancer dan sebagainya itu. So this is, I think, one of the biggest problem, Pak Peter, because we launched the system in 2014 with a very, very big or large medical package. This promises maybe difficult to be like deliver, or if it is delivered only because the supply side problems, only BPJS members that close to the big teaching hospital that can benefit from the very high technological or large benefit. And this is what's happening in 2022. MOH planning for this KJSU ini apa? Pengembangan kanker, jantung, stroke, dan uronefrologi untuk daerah terpencil. Dan ini jadi masalah betul ketika bicara mengenai paket cath lab untuk jantung dan untuk stroke ya. Ini membutuhkan kemampuan daerah ya, dari mulai SDM-nya, kemudian juga listriknya, PLN, gedung peralatan macam-macam ini. Nah, ini yang sangat sulit dan bisa terjadi kegagalan di sini. Dan ini pun sekarang dilakukan dengan berbasis pada dana pinjaman from the World Bank. Itu Budiah ya, maksudnya ya. Ya.
Baik,
Ada
terima
komentar
kasih.
nggak? Artinya Budiah termasuk yang skeptis nggak mengenai cat lab ini ya? Karena ada beberapa orang yang skeptis, mana mungkin cat lab itu bisa diberikan ke daerah terpencil ya. Tapi kalau itu tidak bisa diberikan, berarti seharusnya tidak diberikan oleh BPJS ke semua provinsi di Indonesia. This is the biggest. What do you think about this?
I would just add, I think, and
Uh.
this is one of the, I think, experiences that is emerging from the research in Indonesia, and especially the research that Prof. Laksono and colleagues here at UGM have been doing, that the provision of an entitlement does have an interface with the supply side, the ability to fulfill the entitlement. And so if the supply side is very unequal in different places, then the financing from the entitlement will flow to the places with better supply and not to the places with lacking supply. Now, that just to me says something very explicit must be done to reduce the inequality in supply. It's not just about financing the demand, right? And insurance has typically been a structure for financing the demand, right? So we need to think in national health systems about how to balance that. And especially this comes out quite significantly in Indonesia because of the geography. Because, you take a case, we were talking yesterday, a case like Taiwan, it's a one island, good transport system, higher income, and you can compensate for this geographic variation. But in Indonesia, it's more difficult. So I think that means that needs to be part of the health system development policy. And we are seeing some efforts in that direction, and that's a good thing. And the other question I think that is important is that the accountability to the population in different areas. There needs to be some mechanism. There needs to be mechanisms for feedback from the community to the system. What needs are, you ask about priorities, the community should have some voice in these priorities and these investments, and some structures need to be set up to do that. Now, I think there are some things in place to do that, but they should be supported and they should be made to work better. So thank you very much for that very difficult question.
Okay, next question from Pak Bambang from PK-KMK. Silakan Pak Bambang.
Ya. Terima kasih, Prof. Sangat menarik tadi yang disampaikan oleh Prof. Dr. Berman dan yang difasilitasi oleh Prof. Laksono ya tentang pentingnya transformasi pembiayaan kesehatan global khususnya pasca Covid-19 yang lalu. Sampaikan ya tentang perlunya inovasi dan perluasan cakupan jaminan kesehatan menuju UHC di Indonesia ya. Ada beberapa poin penting yang mungkin untuk pengembangan di Indonesia yang mungkin nanti ke depannya juga terkait yang biasanya Prof. Laksono sampaikan untuk kajian atau penelitian ya. Di kita mungkin perlu diversifikasi sumber pembiayaan yang selama ini ada, kemudian juga perlu inovasi model asuransi, istilahnya seperti blended model, kemudian meningkatkan efisiensi dan transparansi kalau dari tadi diskusi ya. Kemudian juga tentang bagaimana strategi kelompok rentan yang memang di kita itu cenderung khususnya untuk private health accord itu kan ke formal, non formalnya dan kelompok rentan cakupannya belum banyak seperti itu. Kemudian juga penguatan peran pemerintah daerah tadi disampaikan ya. Dan yang terpenting memang regulasi dan kebijakan yang progresif dan yang terakhir pemanfaatan teknologi digital kalau kita lihat. Sehingga memang kedepannya kolaborasi antara kalau di Indonesia pemerintah pusat, daerah, kemudian sektor swasta, termasuk juga akademisi ya serta masyarakat sipil harus terus diperkuat untuk memastikan setiap individu terutama yang rentan, yang belum terlayani. Memang di negara kita tadi sampaikan Prof. Laksono sangat luas ya dengan variasi masing-masing. Itu mungkin kalau saya tadi mendengarkan dari Prof. Laksono dan Prof. Berman. Itu dari saya, Prof. Laksono. Terima kasih.
Ya, makasih. Nah, Pak Bambang, nah justru ini Pak yang kita perlu betul untuk teman-teman di FK-KMK nanti Prof. Asnawi juga sudah mention ke saya juga ya. Kita masuk ke ini UHC itu sebagai suatu hal yang kompleks ya, tidak bisa hanya dilihat dari 98% kita sudah mendapatkan kartunya atau menjadi tercatat tadi. So I will Mbak Bibit bisa nggak saya dibuka Mbak Bibit apa saya dikasih share screen. I will Pak Bambang ya use what Pak Peter mentioned in his presentation about the universal health coverage service coverage index. So I've found this in WHO web. Bisa dibuka ya? Yeah, okay. So actually it's very interesting that yeah, okay. Yeah, this thing that you mean. Yeah. So can you explain more on this? Because actually, I have read this since 2 years ago, 3 years ago, and we Indonesia actually, although we are the biggest or the most maybe populous members of BPJS, but our service coverage index is low. Can you explain what is in more detail, Pak? Pak Bambang, ini mungkin perlu untuk BKPK lihat ya. Ini ada semacam indikator global yang tidak hanya pembagian kartu ya atau membership, tapi tadi yang Pak Peter katakan, silakan Pak Peter. So please.
Yeah, you can see I didn't remember the total number. I didn't use it. I have a slide, more detailed some slides on this, but if you go to the global monitoring report, you'll see all the details. This chart says there are 14 tracer conditions. So these include things like antenatal care coverage, immunization, treatment of acute respiratory infection, tuberculosis treatment, HIV, malaria, and also there are several adult health indicators related to non-communicable diseases like effective management of hypertension, diabetes, and so on. Now, Indonesia has, for these conditions, if you will, the health system, both the government and the JKN system, do give people entitlement to treatment and care for these conditions, both the prevention and the curative ones. But the coverage of that entitlement is not 100%. And as we have seen, and you know quite well, even when you do screening for hypertension, the care pathway to effective management of that hypertension requires more than screening. And it requires some interventions, some follow-up, sustaining that, and so on. And that's where the system still has need to improve, right? So you know this quite well. Now, does this service coverage index cover more advanced medical care, like surgery for cardiac problems or cancer or something? No, it does not. It's not included in that. It's really representing more this SDG 3.8 concept of essential, priority, basic, except that they just picked some indicators that are widely seen to be part of this without defining specifically essential, priority, or basic. Now, if we were to say essential, priority, or basic is only these indicators, I don't think that would be acceptable either. So they are indicators. They are not the whole bundle of the package. So what is the bundle of the package? That's the question.
Yeah. So Pak Bambang, mungkin ada komentar nggak Pak Bambang? Halo, dari BPKPK ya. Oke, jadi intinya begini ya, kalau kita lihat ini kan seperti indikator yang 14 tracer tadi ya, ini kan tidak tadi seperti cat lab itu tidak ada di sini. So cat lab is not here, oke. Tetapi tadi ketika BPJS dimulai 2014 itu sudah masuk di situ. Jadi so this is the example of how large is our benefit ya. Dan yang jadi isu kunci itu yang mendapatkan plan cat lab itu hanya sebagian kecil dari Indonesian ya. Tapi mengambil dana banyak dari BPJS. Tapi tidak dihitung di ini di indikator ini. Jadi ini kita menghadapi sesuatu yang sulit. Makanya kalau ranking kita rendah di sini, 55 is Indonesian rank ya. Is that right? Yeah. Yeah. Value, no, score. Yeah. Okay.
The BPJS benefits do cover many of these interventions, but BPJS does not provide the financing for most of the costs of these interventions. It provides some supplementary financing to the governmental PHC system, but the bulk of the financing and the studies we have just done with the team I work with from ThinkWell Institute in Indonesia suggest that it's only about 10 or 20% of the full financing of these services. And in the government primary healthcare system, most of the funding is coming from central government transfers to the district. The revenue sharing to the district, the DEACA, it's called, and the Ministry of Health budgets and others, right? So this is important to note that you have this mixed financing system. It's complicated. Some of the we had a session in the conference last week about fragmentation in PHC financing because the Puskesmas can receive money from 10 or more different budgetary sources. And sometimes they have different rules and regulations, reporting requirements, and so on. Some of that is JKM also, right? But this may be making it more complicated to try to achieve the service coverage index.
Yeah, so that means this index is not UHC meant by BPJS. Jadi ini UHC yang sering dilihat BPJS itu adalah UHC yang tadi dalam tanda kutip 98% participation membership tadi ya. Sementara yang di sini ini tidak hanya terbatas pada apa yang diberi BPJS, tapi UHC yang sampai ke tadi dana dari pemerintah, di mana untuk layanan primer itu hanya 10% dari BPJS. So the others from the local and the central government budget. Nah ini yang menarik ya. Jadi definisi UHC ini, so, please correct me if I'm wrong, Pak Peter ya. The UHC definition is not only in financing coverage of membership, but it is more this WHO definitions of UHC service coverage index. Is that right? Yeah.
Let me try to see if I can make that a little clearer. So WHO, World Bank have come up with an index of service coverage, which is actual utilization of services, which reflects mostly a fairly lower level of service delivery, that much of which can be done through primary health care. Okay. Now, that is an effort to reflect this SDG 3.8 concept of UHC. And there also is an index of financial risk protection, okay, which I showed you before. This, when you say the concept of UHC from BPJS, when they say most people in Indonesia are members of BPJS, they are covered by BPJS, meaning they have an entitlement. We use the word entitlement, but that entitlement may not actually be realized. Okay, so this term coverage in English, and it also comes from Spanish, cobertura they use in Spanish. It has two meanings. It means a membership, an eligibility, and it means an actual. And we need to be clear which is which. So yes, BPJS has achieved very high coverage in Indonesia, and that is very good. That's a very positive development. People are aware of their entitlement, and you should be proud of that. But the gap between the entitlement and the actual, that is a challenge for the future.
Yeah.
I'm trying to be.
So that's why in this map, this is score. This is 55. Yeah. And then if we have a light blue like my shirt, why I'm using light blue. Yeah. But if you look at the European countries, Sweden is 80. Yeah, UK is 80. And Canada, where is Canada? Oh yeah, Canada. Canada 80.
That's pretty much. So the question is this effective coverage? I would say that they did not carefully measure the quality of the services in all these settings. So I wouldn't assume that it is always effective coverage, meaning of good enough quality. But we hope so.
Thailand is 80, best in Southeast Asia, Thailand. The Philippines, 58. It's better than Indonesia. And this is the same with maybe Congo. Oh no, Congo 42. Chad, somewhere in Sahara, I think. Chad. Yeah. Yeah. So I think we are not so good. Malaysia is 76. Oh, okay. So this is the okay, see that. Yeah. You can comment on this or new things? Yeah. Okay. This.
Yeah. Okay, thank you. Yeah, so if we look at the indicators for this surface coverage, again, as Peter has mentioned, it's covering surfaces that are mostly can be handled at the primary level, right? So it is reproductive, newborn, maternal, child health, which include family planning, antenatal, immunization, and also care-seeking behavior. And then infectious diseases, which cover TB, HIV, insecticide use, and basic sanitation. And then non-communicable disease, which cover hypertension, diabetes, and tobacco. And then talking about surface capacity and access, I think this is the most important thing when we think about the surface coverage, because because then the surface capacity and access talking about not only hospital beds, but also human resources availability, and also compliance and the rating at the International Health Regulation Index. So that's kind of covered, most of the basic services at the primary level, but also the ability or the capacity of the surfaces to be functioning as it's supposed to be. So that's about the surface coverage index. And about the membership also, I think Pak Menteri, Pak Budi, mentioned in the opening of the IHEA conference last week. So this week, he mentioned that what we provided at the moment is the right to access, just the rights to access, but not necessarily their ability to actually access and utilize the services. And this has been reflected in a lot of findings from research looking at those who even have membership with JKN doesn't necessarily use the JKN services. So they probably opt out using OOP instead or using other financing. And in terms of the coverage for membership, that is 98% at the moment, Pak Gufron also mentioned that actually this is just membership, right? I mean, we need to think about active membership, right? If we are going to address the issue of sustainability of JKN, and in terms of UHC, achieving UHC, then we need to think about their sustainability as well. And looking at the number of people that are covered by membership of JKN, almost 60% are PBI, right, the subsidized government paid, right? 40% is those who are supposedly paying members. And out of these 40% members, in fact, only around 50% who has active membership in terms of paying compliance, and very, very low compliance with the others of the remaining members. And within the 50% who are actually paying, most of them would be employee, right? And the employer compliance rate for payment is only 80%. So it's really it's really affecting the sustainability of JKN in terms of revenue that they are collected. And they have acknowledged that they have 80 trillion, if I'm not mistaken, revenue, which is 50% only of the annual target. And the claim ratio is more than 100%. So meaning they are spending more than 80 trillions. In fact, they estimated that with the remaining 490 trillion something money that they have, they probably could sustain it until only 4 months, if I'm not mistaken. And their investment return is only 500 million per annum, which is not enough to cover the rest. So I think at some point we're going to come back to the situation back in 2018, where we have, well, the government has to think about whether we need to bail out JKN because they are just too big to fail at the moment. So I think it bears the question also with the capacity of the government to provide the funding to bail out, because as you mentioned, post-pandemic, even though the economics is, slowly recovering, the presentation from World Bank also during the pre-conference mentioned that Indonesia is basically running on loans at the moment, right? Because we owe World Bank, 22 billion something. With ADB, we borrow 5 billion something, and then with other banks as well. So we are running on loans, and loans are having some requirement, and we need to consider our ability to repay the loan and also the interest with our current low economic growth. So this is really, really crucial moment for us to think about what can we do to save the financing for the health and also the sustainability of service coverage. Thank you.
Thank you, Ushita. So you really focused on another issue we haven't talked about, which is, we've been focusing on the challenges of delivering the services that are being promised, but there is a big challenge in raising the money as well. And this is true in many countries around the world, especially where people are not engaged in so much formal sector employment, where they have a job with a salary and an employer who pays taxes. And we find that in insurance schemes around the world, that the people who have formal sector employment, it's easier to collect the contributions from them than from the people who do not have that formal sector employment. One of the approaches in many countries has been for the government to say, okay, we will pay the premium for the people who don't have the formal sector employment or who are too poor to pay the premium. But then that does create a big challenge for the public funding, right? So yeah, I think you explained that quite well, and these challenges are well known here. I will say that yes, Indonesia does have a significant debt burden. That's not necessarily a bad thing. The purpose of the debt is to accelerate the growth right? And if the debt works well, then repaying the debt can be done because the economic growth has been successful. And Indonesia has many potential for repaying the debt. One of the reasons why some of the African countries right now are in greater challenge is that they haven't been what I called as good a credit risk, not as good at confidence that they will repay the debt. But you are right, there should be balance and caution in thinking about this. So I agree with most of your comments, and this is another aspect of the challenges being faced with the health financing structures. And I will say also that, you know, in Indonesia and in many other countries around the world, when one creates these new financing structures like JKN, and you still have a very, very large government operated, funded delivery system with civil servants and so on, this balance has been a challenge, you know, because the salaries of the health workers around the countries, they are not being paid by JKN. They are supplementing those salaries. And this is another challenge, how that transition going forward is going to take place. So thanks.
Okay, Pak Peter, there's a question in the chat. Can you show from Ibu Fira from MOH? She is an economist in the Ministry of Health. Yes, please.
Thank you. That is also a challenging question. Let me say, I do think right now that there are both reforms needed in financing and governance. Let me talk about governance first, because that's something that I have a particular interest in. You know, I know that the new omnibus law has many specifics about this. I will confess that I have not been able to go through it in great detail, as well as to understand the meaning of everything in there. My Bahasa Indonesia probably needs to be better. But I do think that right now you are experiencing the challenges of multiple sources of decision-making authority affecting the ability to more efficiently and effectively manage the health system. And these certainly include the BPJS, the Ministry of Health, other ministries at the central level, the significant decentralization of capacities to the kabupaten, and also some of the initiatives around the village level activities. As Prof. Laksono said, I started my work here about 50 years ago, and I did have an involvement in the early development of Posyandu. I'm very gratified to see that it still exists, but it does have a need to be updated to the new situation, and that is underway. So I do think that these governance issues are quite significant. I've also noted in my visits to Indonesia recently that the role of the province has not been as clear as it used to be. The dinas in the province used to be much more directly involved in management at the subnational level, and it seems to be less so today. So I think you can see that you have a complex set of governance reforms that have taken place, and that there still need to balance these. I would give that a very high priority. I think that unless that is sorted out in a more effective way, there's always a danger that even though a policy is made, the actual adherence and implementation of that policy is difficult to guarantee. On the financing side, I think Ibu Shita has shared with us some of the very specific issues, and they have been well documented by researchers. And I would say that there is a need to try to define more clearly the priorities for financing, what is being financed going forward, and to try to put in place measures to try to assure that those priorities are actually given greater priority, right? And now the governance challenges inhibit the ability to do that, right? Well, I won't say probably, but there could come a time where, as Ibushita has said, it may be necessary to, as the word she used was bail out the financial challenges. I'm trying to be very polite, so I'm the foreigner here. And if that happens, that usually is the pressure point where these reforms have to be addressed. So I think that it is good to be prepared in advance for that, and to have for the leading thinkers in the health system to have in hand some significant reforms in both governance, financing, benefit package that could be put forward to prevent a situation from turning into a very negative situation. Fortunately, you do have some positive momentum in the economy and in the world and in the region, and that may help to make these future reforms needed less unpleasant. But I think there will be some need for some further changes. I hope that's been a helpful answer. And I know many of my colleagues around the world also feel we would be hoping we can in some way contribute to helping you address some of these challenges.
Yeah.
I want to say one other thing just in response a little bit to Pak Bambang's comments as well. The diversity in the environment in Indonesia is very significant. The geography is very challenging, and there is a need and a potential for greater technical capacity in the decentralized setting. Universities like UGM, the other regional universities, UNPAD, Udayana, in Sulawesi, in Sumatra, they need to play a greater role in supporting the local governments to improve the efficiency and management, and also to educate the people who are going to be the managers of the system. I'll give a little personal plug here. I had a privilege of being involved at Harvard University in the development of a Doctor of Public Health program. And the Doctor of Public Health program is intended to be a program at the doctoral level, an advanced education program, but not so much about research, but about policy and management, right? And to develop a cadre of people who have the capacities and skills to carry out those responsibilities. I think that is going to be something that those competencies and capacities are going to be increasingly needed in the systems, not only at the central level, but at the more local level. And I think that the universities in Indonesia have a very important role to play in helping to meet those needs. Thanks.
Ya, ini yang jadi isu kunci ya. Memang tadi Bu Sita katakan menarik ya. Kita tidak tahu apakah andai kata BPJS problem keuangannya ini terus berjalan. Karena sebenarnya kalau kita lihat BPJS problem sekarang itu harusnya terjadi 3 tahun lalu ketika waktu 2019 sudah terjadi kenaikan, tapi tetap minus juga ya. Untung ada, untungnya. Tapi ada Covid-19 yang memberikan tambahan dana untuk BPJS sehingga BPJS punya surplus. Nah, tapi ini yang menjadi pertanyaan besar ya. Nanti ketika defisit, ketika situasi bangsa kita tuh banyak pinjam uang ya, artinya memang kapasitas fiskal pemerintah pusat itu tidak kuat. Itu apakah akan ada semacam ya bailout ataupun tambahan dana APBN atau kenaikan premi? Nah, ini juga menjadi pertanyaan-pertanyaan yang masih belum bisa kita jawab sekarang. Jadi ketidakpastiannya tinggi sekali. So, jadi ini yang jadi isu kunci ya. Artinya kita dalam situasi yang memang tetap harus alert ya mengenai apa yang akan terjadi di masa mendatang. Oke, berarti the time is almost up. Pak Byron, there's one, sorry, Pak Berman, sorry, there's one, Bu Julita. Bu Julita, yes, maybe can we open this?
Iya,
Mic-nya apa? Bu Julita, can you speak up, please?
okay. No, okay. Thank you, Pak Laksono, and so Pak Peter. In my opinion, the sustainability of healthcare financing in Indonesia is currently quite worry, which will impact the sustainability of hospital or provider. As we know, the most hospital in Indonesia are highly depending on JKN patient, whose rates are often below, but the tariff is very low and under the hospital unit cost. As the result, many hospitals are forced to be sold and bought by corporations with strong funding. What's your opinion on this phenomenon, Mr. Peter? Does this also occur in the other country, and what the solution? Thank you.
Okay, thank you, Ibu Julia. I haven't studied this issue specifically in Indonesia, but I have heard about this. And I do think this is another potential area of consequence when the entitlements exceed the resources that are available to finance them. And then you can see that this has consequences not only for the on the demand side for the utilization for the patients, but also on the supply side.
Yeah.
These consequences may create longer term changes. So I do think that we see this in other countries, and we do see that hospitals are put in a difficult position, especially government-owned hospitals, because they cannot really deny care to people on a cost basis. They do have ways of buffering this problem, waiting lists, being oversubscribed, insisting that patients purchase externally inputs that are needed for their treatment. We see this all over the world, and I know this is also taking place here. So again, this is about finding the balance between the entitlement, the demand, and the funding, and it also does reflect the this complexity of having a financing agency like JKN, which is separate from the service delivery provider, which is often the government at various levels. Now, this is also has to do with the levels of governance, because you have the referral hospitals often under the provincial administration, or sometimes other structures. And then at the kabupaten level, you also have now the kabupaten, the dinas, that has to finance both the hospital as well as the primary healthcare, right? And there's some interesting financial dynamics there, where they are getting some money from JKN for the primary healthcare capitation and some other money, but also they are getting paid for service delivery costs at the hospital. And what is the incentive dynamic there for the district administration? I don't think we have looked at that. I am not familiar with anyone having studied this. So you are very right to be concerned, and this is not a unique challenge to Indonesia. Ultimately, the solution is to find the balance between the benefit entitlement and the financing. But as we've discussed already, that is also a governance and a political and other aspects to that question. So I'm sorry, I can't give you a simple answer, but it's
So
important
maybe
to be aware.
the cost sharing is
Yeah.
the best solution now.
Yes. Yes. And perhaps, this is, the notion that that there may need to be some cost sharing with the patients. But and the challenges, the equity issues that raises and so on. We have seen countries include cost sharing for better off patients and exemptions from that for the poorer patients, but that is difficult to implement and also puts a burden on the local hospital to be the one making that decision. So yeah, you know all this. Thank you.
Okay, thank you, Pak Peter, Bu Lita. Okay, I think to to end this meeting, Pak Peter, maybe I have to raise one issue. Interesting that also Bu Yulita mentioned about the impact of BPJS problems to the hospital. Yeah. And I remember in 2000, early 2000, 2005, 6, 7, it was like the heyday of what we so-called like healthcare reform movement. The agenda for the Harvard groups using the control knobs. Yeah, okay, at that time. Yeah. And I was also invited in Washington DC for this purpose, and then we make some series of training. But after or before COVID and after COVID, it seems that this kind of reform movement is disappearing. I asked Sita when she was in Nagasaki for the health system conference. There's not many people discussing about this. In ADB, only our minister, Pak Budi, that he explained the total reform using transformations approach in Indonesia. But the other countries, it seems very, very little. And also in this this week Bali meeting for the IHC, also not so much discussion on total healthcare reform. Do you have any analysis on this? Am I right in my observation? It was like the heyday, like the peak of the healthcare reform movement, but not disappearing.
Well, I was interested in this observation that you shared. I think that your observation has some validity. I think the attention of the world shifted to UHC and PHC and not so much overall health system design. Now, in different countries, they are dealing with this in practical terms. I mean, when but the field of study of health systems analysis and health systems reform has not, I think, kept up with the attention to UHC and PHC. I think it should, and especially it doesn't have to be necessarily health system reform, but comparative health system analysis and learning from different. We use the terms in the health system field, macro, meso, and micro, and I think there's been a lot of attention to micro, some to meso, and perhaps not enough to macro. But I think there's a lot that can be learned meso level that can also help countries with the kind of challenges facing Indonesia today. So as somebody who was, I think, a participant in that period of time, I'm a little sad to hear your observation.
Yes.
But I hope that we may still see much interest in this as countries grow and evolve and face new challenges. One of the problems in the health sector reform study field has been that countries used to be more easily given a kind of a typology. This country has this type of health system, this country has that type of health system. I think today we are seeing a lot of blended structures, mixed ownership of delivery, mixed financing, and this makes it more difficult from an academic point of view to draw clear analysis of causation with system design. We had a session at IHEA about this. And interestingly, much of the research was very micro-focused.
Yeah,
How
that's it.
systems affect treatment of a particular disease or something, rather than the overall structure of the system. So I hope we will, since I spent most of my life on this field, I hope we will not see it disappear completely.
Yeah,
Thank
okay.
you.
I think that means we have to make like regenerations, because like at that time, so many names like William Shaw, Thomas Bossart, Michael Rates. Yeah. So they don't have any successor or younger researcher at Harvard. Yeah. Yeah.
They do, and we do have these regional health system observatories that
Yeah.
were created. Your observation gives me concern, but I would not be so pessimistic. Yeah.
Okay. Yes. So please, because we are now implementing the reform at the moment, the law, the head law in 2023, actually it's total reform, using the control knobs of the World Bank and Harvard University. Remember that? Yeah. And I was in 2007 course in DC on this issue, and actually it's totally using this approach. And the political debate is so intense on this. So this is a big example, and this is the risk or the challenge for Indonesian, how to we implement this law, and hopefully we can have like counterparts. And for the young researchers here, I think this is becoming one big issue for Indonesian's health system development, how to implement the reform that is politically already decided. Yes, we go to this total transformations. But the implementation is another story that is becoming very, very difficult, yeah, very technically complicated. And I think this is a big opportunity for young researchers to play around on this reform process. Okay, I think this is the end of discussion about the global health finance after COVID-19 and the future of UHC. So this is not only the knob of financing, but we have to think about provisions, about human resources, about pharmaceutical and medical device policy, about informatics, leaderships, and many things. Okay, thank you very much, Peter, for your time, and hopefully you can fly home safely, because Pak Peter has to fly tomorrow evening from Jakarta to Istanbul, okay, and then from Istanbul to Boston. Still long flight. It's about how many hours? More than 20 hours, I think. Yes. So safe trip, Pak Peter, and please come back again to Indonesia maybe next year if there is a meeting here, or we can go to Boston. Yeah, somebody from Indonesia should go there, I think, to.
Can I offer my thanks also?
Yes, please. Yeah.
Saya juga mau ucapkan sangat terima kasih pada Prof. Laksono dan semua teman-teman di sini di UGM. Saya tinggal 2 tahun di sini di UGM, tahun 80-an, 81 sampai 83. Itu saya melaksanakan.
Belum lahir.
Ya, waktu melaksanakan penelitian saya di Jawa Tengah tentang sistem kesehatan, masalah-masalah yang saya meneliti banyak masih ada dalam sistemnya. But it's very, very nice for me to be able to come here to Jogja, and I want to thank Prof. Laksono for the kind invitation. And I'm very, very impressed and excited and positive about the work all of you are doing. So congratulations on that, and keep going.
Thank you, terima kasih. Saya kembali Mbak Laras, terima kasih.
Okay, we would like to extend our sincere appreciation to Professor Berman for today's insightful presentation and discussion, and also to Prof. Laksono for moderating the session. Our appreciation also goes to all participants, both on-site and online, for your active engagement and thoughtful contribution. I am Raras, and on behalf of the entire team, would like to say thank you, and we wish you a pleasant day ahead. We look forward to welcoming you at our next event. Wassalamualaikum warahmatullahi wabarakatuh.